through fiscal and billing considerations with the CCBHCs who will be starting on July 1 of 2026. Things that we want to talk through are what's going to happen with the cost report, what's the next step for review, implementation expectations and risks, qualifying services versus support services, rebasing, potential rebasings, payer mix considerations, benefits for Vermonters, and lessons learned from Claire Martin and Rutland process. So everybody submitted their cost reports, so thank you very much. We received them all by the deadline, and we have received a couple of revisions. So we appreciate all of that. Sorry, I'm being a little distracted by some of the things that are flashing across the screen. So we wanted to chat through what kind of are the next steps and how these reports will be reviewed. Feel free to ask questions as we're going along. If there seems to be a lot of questions that we think are going to bring us beyond the time limit that we have, I think we'll have to maybe have a parking lot for questions and potentially have some follow-ups. So what happens next? So next steps are to review the cost report with DMH, VDH staff in collaboration with a contractor that has been selected through a bid process. So a contractor has been chosen, however, may not begin until mid-January, and I can't really say who that is because we do not have an executed contract. That is in the works right now. We're hoping, like I said, for beginning to mid-January timeframe, but that's probably pushing a little bit for that timeline. DMH will begin reviewing the cost templates for completeness and internal trainings. We'll assume, so you should assume that there are going to be multiple meetings with the contractor and DMH during this cost report review. There may be need for clarification or corrections. So just expect to have multiple meetings and a lot of back and forth. Reviews are expected to be completed and PPS1 rates set by April 1st. That is an internal deadline. We really need to get these moving as quickly as possible, understanding that that is a very fast timeline. So just wanted to put that out there. So timely responses to questions and requests for meetings and information will really be essential to meet that deadline. And of course, the demonstration year to first year for the second year, for the second cohort will begin on July 1 of 2026. So how will the cost report be reviewed? All aspects of the cost template will be reviewed for completion. We do have a tool that was developed during the last contract, and that tool will be used to kind of as a checklist. We'll talk about that a little bit more later. So reclassifications, adjustments, and anticipated cost tabs must match the trial balance. There are various columns, so all of that does need to match. Supporting documentation must balance to each tab in the cost report workbook. So any backup documentation, spreadsheets, really the totals do need to match what's in the cost report. And they also need to match your trial balance. So that's really important. Let's see, non-CCBHC costs must be clearly indicated on supporting documentation for review processes. Things like reach up, residential facilities, other programs that are not part of CCBHC really need to be clearly indicated on your backup documentation so that we can have a good sense of so that we understand that those costs are really pulled out of the CCBHC costs. Salaries will be compared to the Bureau of Labor Standards Statistics, BLS, standards for each occupation. And then we will require justification for salaries that are above BLS. So if you have staff members who have been there for years and you've already, they have tenure, it's possible that they may be above the 75% BLS, and we would not expect you necessarily to reduce those salaries, obviously. So there are some instances where things may go above the 75% of BLS. We want to see them between 25 and 75%. So that's just, I think that's what Nicole and I have talked about before. The daily visits will be reviewed for reasonableness and must match what's on the supporting documentation. Services per visit and services per full-time FTE. So there is a worksheet for number of services per FTE or per category of staff member. Comments on the comments tab must be clear and descriptive enough for review. There's a comments tab towards the end. So modifications or reclassifications, adjustments, things like that. It will be pretty critical to have that outlined on the comments tab for review purposes. Anticipated costs and visits will be compared to the final PPS rate for reasonableness. We do recognize allowances for client growth and the need for evidence-based practice training for new hires while balancing productivity. So, you know, obviously there's going to be conversations, but there does need to be reasonableness to those visits. Any questions so far? Okay. So obviously implementation will begin on July 1, 2026 with the expectation of correct and appropriate billing. Billing should be monitored weekly at first, but no less often than monthly, to assess billing issues and or system fixes that may be required, and to understand the billing trends or accuracy of units in a cost report. So, you know, Clara Martin and Rutland might be able to give you some more insight into that. But, you know, anytime you implement a new system, you're gonna have things that don't exactly work the way you think they're going to, and fixes need to happen. Both on the provider side as well as on our side. So we did experience some of that. We've been working through it. Madeline's been working through it. Hopefully we've gotten through the most of it. So any billing issues that you do come across really need to be communicated as quickly as possible so that we can address them. And then we also want to make sure that costs are monitored very closely to ensure that they align with the cost report. CCBHC Cost Center and the electronic financial system must have only CCBHC costs and revenues, and the electronic financials must be timely to facilitate timely review. We're going to be setting up a monitoring process. It's really also important so that we can understand how you're doing fiscally, because CCBHC is supposed to cover the cost. So it's going to be really important for us to be able to monitor the visits, your utilization, your revenue, and all of that.
Okay, oh, we have a question. Do you want to take a question now?
Oh, absolutely.
Kathy, do you want to ask your question?
Is it Madeline Powers that we should be working with if we have billing issues for CCBHC? Yes, okay. Just wanted to make sure we had the right contact person.
That's correct. And I don't know why my computer keeps blanking out of the presentation, but yes, I'll continue to be a point person for any billing.
Okay, thank you.
Any other questions so far? Okay.
Oh, that's me. Just switch the slide.
So implementation of risks, and some of you have probably seen and heard some of this before. Nicole and I did a presentation a year ago. Oh, I'm not sure what's happening with, I wonder if you do the other plugin, would that help or maybe no? Or is it just this room? Our apologies. This is, let's try that. Let's see. Nope. Yes, here we go. We'll see if that works any better. So implementation risks. So predicting the anticipated visits in year one is really kind of challenging due to the lack of historical experience with some of the new codes. And then, you know, you should just expect a margin of error. We're not going to get it 100% right the first time around. Review the manual for qualifying versus support codes in place of service when determining number of daily visits. That's going to be really, really important because when you pull your data, you want to know what's qualifying and what's not. So not just the qualifying services, but like, is telehealth qualifying, that kind of thing. Madeline, I don't know if you have any other thoughts on that.
No, I think I guess the only thing to add is just it's only a few instances where it does differ from the mental health case rate world. So I think that can be tricky because it might feel hard to catch it. So if you are feeling like you are not noticing a difference and want to reach out on that specifically, we can talk through it too.
Thank you.
Oh, is that it?
So transparency into all activities or services being provided is really critical. So non-qualifying activity may be used to advise future qualifying services. I know we have some of the services that we have indicated are not qualifying, and that is because that is in some instances because there's not historical data. So it's really important to include every single service on your daily visit so that we can see what activities are being provided, and it can hopefully advise future qualifying services. Let's see, used as part of the desk review process by comparing costs and visits year over year. Qualifying and non-qualifying services are included in the number of visits per position. So in that desk review process, we are going to be comparing costs and visits. And there's a separate tab on the cost report that outlines the number of visits per position. That tab is literally all of your visits. So it's not just the daily number of visits, it's really all of your visits, because that's really going to give us some insight into the productivity. And then spreading of visits. Spreading of visits can lead to lower rates in future years, as well as expectations of continuing that level of service. And really, you want clients to be provided all the services that are needed at the time of the visit. I don't know if anybody else has any other thoughts on spreading the visits. Any questions on this?
So we just wanted to clarify the qualifying services versus support services, why they are different. And I think traditionally there is some awareness and understanding from mental health case rate, but just a redefining of them now for CCBHC. So qualifying services are meant to be and should be the core mental health substance use services. They are qualifying services. They qualify as the minimum requirements on a day, and they will trigger the PPS rate for that day. So if a person receives one qualifying service in a day, they will get the PPS rate. Even if they've received multiple qualifying services, it will still just be the singular one rate for the day. I spoke about the third bullet point already. All costs are incorporated in the PPS one rate through the cost template, and that will be true in the support services as well. So moving on to the support services, these services support the qualifying service. That is not meant to be a clinical reference or term support. but it is meant to say that these are the services that enhance those qualifying core services that are being received. They are part of the comprehensive care for clients who are receiving core services. These are allowable through the CCBHC program, but they won't earn the PPS rate for the day. They are factored in through the cost template in the total services that get factored in to the amount of the budget for the CCBHC. Little or no historical data exists for some of these, and that is also why we don't have them as qualifying currently. I'm thinking of, for example, nursing services as something that we are continuing to leave as a support service because we don't have the complete historical understanding of what that looks like, as it's kind of newly added to the mental health case rate as a part of the state plan. So we are trying to find balance. The payment model balances flexibility by reducing the number of payment triggering service and minimizing service by service accountability with a traditional fee for service model where each individual service triggers a payment and ensures accountability for every service provided. And just to be kind of extra clear on how to be sure about where something is qualifying and not qualifying, if you are looking at the code list, I don't know, I'm sorry to not be able to say which column this is, if it's what letter of the alphabet we're down to there, but there is a column that says qualifying event, yes or no, and that will help you give clarity on whether or not to expect this to be something that will draw down the PPS for the day. Kathy?
I know there's been some confusion about community supports and whether or not they are acceptable via audio only and telehealth. I just want to ask the question, for CCBHC billing, are those community supports acceptable to be billed if they are provided via audio only or telehealth?
So you may deliver the service and bill for it as audio only and telehealth. Community supports audio only telehealth will not be a PPS qualifying service, but all other aspects of community supports will continue to draw down the PPS rate.
So it will not be, I just want to be clear about this because it's been very confusing. We've gone back and forth. So it will not be considered qualifying if it's.
That is correct.
Okay. All right.
Sorry,
Thank
if you wanted to finish your sentence, I didn't mean to cut you off.
No, that's fine. I thought I understood that at the billing managers meeting, Madeline. I just wanted to be clear and make sure everybody is aware of this.
Yeah, I appreciate that because I think you're correct that there has been shift in, well, it's just that we have had changes as the code lists have come out. So, and especially as you move from case rate to CCBHC, there are differences. So this has newly been clarified. And so it's important that we make it clear here we're all together. So once again, community supports, which is code H2015, is qualifying unless it is audio only or telehealth or audio visual. The 93 and 95 modifier, when attached to H2015, will be a support service and not draw down the PPS rate.
Is it possible for you to update the spreadsheet so that is clear?
Yes, if it's not already posted, I have it now on the code. The CCBHC code list now has one row for H2015 without the 93-95 modifier that says yes, qualifying. And then the next row says H2015 and it includes the 93-95 modifier. And then the qualifying should say no. And if it's not online already, I'll make sure to get it online.
Okay, perfect. One other question, and I'm sorry, I have so many questions. I just usually do.
That's the purpose of this time.
Will we be required to submit these services through the MSR, CCBHC services?
Yes, I believe that is currently happening. Yes.
Yes, there's a service code.
Yes, so we will continue use of MSR.
Okay. Thank you.
Mhm.
I'm done now.
Is that, if anything else comes up, is that Ed who's in line? To see?
Yes, it is.
Great.
Just a
Go ahead.
follow-up question on the audio and telehealth community support issue
Mhm.
or distinction, differentiation. Curious because for a couple of reasons, but one is to help communicate with our program folks who are not here today. Why telehealth in particular, but possibly audio only, were changed or considered to be supportive as opposed to qualifying PPS1 services. What's the thinking behind that? Like, I guess.
I wonder if someone else on the team would be able to respond to that. Cheryl or Laura, I don't know.
Yeah, I just unmuted Shannon. This is Cheryl. We're sitting across the hall because I'm recording on the hardwired line. So I just want you to know there was a lot of thought put into this. It wasn't random. It qualifies in the mental health case rate, and that is a monthly drawdown. So it's not the same issue as daily making a phone call and getting a qualifying rate. So that's one piece, the fiscal piece. Like, we have to decide what's qualifying and what's not, because if everything is qualifying, we're just going to drive the rates way down. And then also wanting to make sure community supports specifically happen in the community with clients. We certainly can talk more about this, but I did want you to know that was our thinking on this. As we looked at what we wanted to do in the state, the differences between the CCBHC and mental health case rate, and then how services, how we would want services to be provided so that clients get the most benefit.
And I would like to also make sure folks understand, because I hear this from some folks. Just because it's not a qualifying service does not mean it's not being paid for under the PPS1 rate. Those costs are all included. So it's a math equation, right? So your costs are included. And if you include non-qualifying services in your utilization to calculate the PPS rate, it's just going to drive down your rate, and then you're not going to get the service. So we're asking that you just review what you've submitted for qualifying for services that are part of the calculation, and make sure that you're not including those services that are not qualifying. So there's two tabs. There's the tab that has all the services, and that tab is the one that is the per staff tab, so that we can kind of see the productivity. And then there's the tab that is the actual calculation that calculates the PPS1 rate. Those are not going to match. The services that are calculating the rate are only those qualifying services, those services that are going to get the qualifying hit. However, as I mentioned, it's extremely important that we see every service in your bill, every service that's been provided to that client. So yes, the costs are included. You are getting paid for those non-qualifying services as part of the cost, but they're just not. They're not going to qualify to get the PPS1 rate. Does that make sense?
Yes, it does to me. I suspect a number of organizations will have some adjustments in the math because of the rate, since that communication came out after we submitted cost reports. So just FYI.
Yeah, and I just want to, I do want to mention that it's really super important, and that's why I'm glad Madeline is here showing you how to really look at the manual, because it was included in the manual correctly. It's just that it's apparent that it wasn't super clear. So just make sure when you go through the manual to calculate your daily hits, that you understand really what's qualifying and what's not.
So it may have been in the code list and maybe I missed it. I apologize. But in the actual CCBHC Medicaid manual, the content where it describes it, that got changed afterwards. So, and that's kind of the Bible of Medicaid compliance from, at least has been from my lens. So, just.
Okay, great.
We'll
So yes, we want to
it.
clarify all of it. We want to make sure that it's very clear.
Are there any additional questions regarding qualifying and support services? I don't know that there's too much else to add on the use of the code list. Actually, I suppose I'm not sure if when you've looked at the code list, I'm not looking at the live list right now, but if you click into that green space where it says demonstration service key, that is will define all the acronyms that are listed here in the demonstration service category. So that may give you some additional context about, is this a primary care code, or which sort of group it's falling into in terms of what core service it's connected to. And we have tried to lay out all of the place of services here. If you feel we've kind of gotten that wrong, I could imagine that maybe, something filtered in there. Definitely reach out. I believe we're, on track here, and certainly have noticed things as billings have been going through and happening with Claire Martin and Rutland. So just reach out if you notice anything that you're a little suspect of. We hope it's correct, but of course, there's just so many numbers and things.
So rebasing. So the CCBHC rebasing process involves the adjustment of reimbursement rates for the CCBHCs based on actual costs and client visits. The rebasing process will occur after the initial rate period, year one for each of you, and then every 3 years following the last rebasing. So this has been a point of confusion. I think at one point we might have thought that it was every 3 years, but I did pull the language directly from a presentation from that I had attended, and so this is the language. It's every 3 years following the last rebasing. Rebased rates are based on actual costs incurred and the number of client daily visits during the year. States must submit audited financial reports to CMS, which are reviewed and determine the appropriate rebased rates. So underinsured and uninsured. So CCBHC's report increase in those with commercial insurance. What? Go ahead, sorry.
Sorry, we just had a quick rebasing question in the room.
Hey, Shannon, it's Tim. I just want to clarify. So I think when we were going through this process initially, we talked about how rebasing would allow us to build in new expected costs. So say we were going to be building, a new program. So are you saying that's not part of the rebasing process now, that our rates will only be based off of actual costs and actual visits?
So that is a question that we have out to CMS, right, Laura? I think that is something that we've recently asked. So more to come on that. We will definitely follow up with you on that.
Okay. And then my other question, Shannon, is that I think last year when we all gathered in Montpelier with CohnReznick, we talked about the rebasing being done after year one or after year two. Are you saying it will definitely be done after year one?
Yes.
Okay.
Yes.
Okay.
I have a further question, which I think builds off of what you were thinking too. But if we choose to expand services or new programs, and how that builds into the rebasing is one part of that question. But what if other services or programs that currently exist that are outside of CCBHC Could those be brought in, like Success Beyond 6 or others?
So I think that, especially in the demonstration phase, I think that we do have the ability to do that. But again, before I give a definitive answer, I think we want to get some, get a response from our contact and just make sure that we're advising correctly.
And one more for me, Shannon, do you know the timing? So do we have a sense of when Claire Martin and Rutland will be asked to begin the rebasing process?
Yeah, so we have to, you have to submit your financials to us within 6 months after the year closes. And then we do have to submit to CMS within 9 months, I believe. So the rebasing process, I would say, would start with when we receive your financials.
And then that goes retroactively back to July 1st of that year?
Correct.
Okay.
So what we would do, and I'm glad we're talking about this, Tim, thank you for bringing this up. We would issue you the MEI increase as a temporary increase or a provisional increase. And then when we do the rebasing, that would go back to July.
Okay. Thank you.
You're welcome.
Sorry, did you say the MEI increase would be issued in July and then the rebasing will happen and be retro?
Yes.
Okay, thank you.
Yeah. So CCBHCs have reported an increase in those with commercial insurance and those who may be uninsured or underinsured. And I think we all still have some real uncertainty with what's happening on the federal level, who's going to be qualifying for Medicaid and how other insurance is going to look. So I think that's something that we all are waiting to understand. Medicaid billable services are the ones that pay the PPS rate. It is a Medicaid service. Sites with CCBHC grants, I think, can use some of their SAMHSA funds, hopefully to offset those costs. Although I don't know what your grants look like, so I'm not sure exactly what you'd be able to cover, but that's our hope. But we also have the Medicaid investment funds that may be used to offset the cost of those as well. So for CCBHCs, when you come online on July 1, you'll be able to use your PPS 1 rate to draw down those Medicaid investment funds for folks who are uninsured and underinsured. The local CCBHC can negotiate, discuss covering costs. The state cannot engage in these conversations with commercial payers. I think we did some work to try to bring in some commercial payers with the system back in the earlier time, but so in some states, the commercial insurances are beginning to cover CCBHC services. Hopefully, more insurance companies will come online and understand the value. Train providers to know about the new regulations and help ensure everyone can maintain Medicaid. Know about Medicaid for the working disabled, for those without Medicaid currently. Any thoughts, questions around that slide? So CCBHCs are required to serve all individuals, regardless of their ability to pay. So this means a CCBHC cannot deny services based on a client's insurance status or payer type. A CCBHC must implement a sliding fee scale. I think you all have a sliding fee scale so that you can, rates can be adjusted according to the client's financial situation. However, this does not mean that a CCBHC must provide the service that a client chooses to decline, either because the service is not covered by their payer or because they still find the sliding fee unaffordable. So you can't deny You can't deny their service, but they can decline it if the cost is too high. If a CCBHC decides to provide a service that the client has declined, the cost incurred becomes part of the CCBHC's uncompensated care. This clarification ensures that CCBHCs remain accessible while also recognizing financial limitations and client choice. Vermont Medicaid will not pay the PPS rate for out-of-state individuals with Medicaid coverage on their home state. So you will have to work with that state's Medicaid system. And then when an individual is dual eligible Medicare and Medicaid, Medicaid will pay the portion not covered by Medicare. That's something that we implemented recently, and I believe it's back to July 1 for the two CCBHCs that we have. I don't know how that's working, but the intent is that we will pay the cost up to the Medicaid PPS1 rate for Medicare dual eligibles.
I guess that brings us to kind of our final discussion of lessons learned. Are there any questions before we, any outstanding questions before we kind of hit this closing slide?
Yeah, and are there things that we didn't cover that you wish we had covered? That's a loaded question, but I just want to get it out there because I want to make sure that this remains a good partnership and things are clear. Great.
We've got a question.
Oh, sorry. Ed.
Just popped up.
Hi, I'm back.
Great. You have great questions.
So I'm just curious in terms of lessons learned, like how is the encounter roll up into the PPS1 billing claim working functionally for the two organizations and or Gainwell? Because I envision I don't know how big yet for the system, but some increase in administrative burden to make claim adjustments to these PPS1 bills as a result of having to tie these together as opposed to doing sort of a bundled PPS1 rate, which is effectively what that is. And then you just submit the encounters separately and we reconcile them based on very simple reporting criteria. So I'm just curious because I don't know how, I know there was some significant delays, at least early on in the summer for the organizations for a variety of reasons. And just curious if that, how is it really working now for them and for Gainwell? If maybe I don't know if anybody from Gainwell's here can speak to it, but just curious.
I think if I'm understanding the question correctly, I would say that there were significant bumps in the road. Gainwell did everything possible to set the system up, and then there were sort of issues like code by code that we just are uncovering as billing has happened. I would say this month, we're really starting to see claims flow, I would say a lot more smoothly than they have and very, very much consistently. I think that the T1040 code, which is the requirement for submitting, you submit that when you have a qualifying service, and then you attach all of the services that happen in that day to it. I think it's working effectively, but there have been some kinks that we've worked out. Yeah, I think Claire Martin and Rutland might speak more to that even too, just because there may be some outstanding issues that that are still in progress for being fixed. But from my side, it does look like things are moving a lot better. and more consistently. I see VCP.
Yeah, so this is Steve Conti, Chief Financial Officer of Rutland Mental Health. Speaking of specifically to the administrative burden, we've had to take 2 additional FTEs to do the administrative portion of billing our PPS1 rate, and this is due to our EMR. We have Credible by Qualifax, and it is a very manual process to calculate the PPS1 combined with the encounter data. I can't speak to NetSmart, which is what Clara Martin's using, but yes, it has significantly increased our administrative burden.
Yeah, so this is Tim from Clara Martin. I think it's a mixed bag. You know, there are some issues. There were certainly issues to start off. It's certainly gotten smoother. If, you know, we were just talking about if there are adjustments that come in later on a claim you've already sent out, then you need to recoup and resend the entire claim, which is a significant increase in burden for our very small billing office. So, you know, nothing is, you know, it's certainly not perfect. I do think it's getting better. To your point, Ed, just in general, it is definitely more work than it was billing under the case rate.
I appreciate that extra context from both of you. I want to add just on the, I think like just a couple of those issues that I'm hearing. I think this speaks to the communication piece. So it's been very, very great to kind of have the constant contact. I am hearing directly from both of your billing managers who are working effortlessly to get this done. And it has really helped like kind of triangulate. So like if you're getting held up with a conversation with Gainwell but you can come talk with me about it, like we're all able to, like, I think things are able to move a little bit faster in that way, you know, and things get escalated because of CCBHC. So thank you for the communication that's gone into this. And I do recognize there, I mean, we talk quite frequently, so I recognize that there has been quite a lot of work here. I am hopeful, I'm not sure if this is naive of me to think that the work that's gone into this from Clara Martin and Rutland is going to actually allow for the next group to have a little bit more of a seamless transition. I do recognize still there's like the administrative piece of setting up your EHRs. That part I can't speak to, of course, but the billing pieces that are now fixed and resolved because of just the claims going through and the work that the things that have been noticed and brought to our attention because of it, like it mostly will be resolved for the next group. So truly thank you to Clara Martin and Rutland for like bearing with us through a big transition. It's noticed your work has really been so imperative to getting this going.
I see we have a question. Is it Kathy?
Oh, I think Katie, I'm not sure.
Kathy Monty.
Kathy.
It's me again, sorry. Referring provider, will that be required for CCBHC?
Are you wondering for supervised billing?
No, I'm talking for CCBHC.
So
will we need to have that referring provider, not rendering or attending, referring provider as the supervisor on the claim?
Right. So no. So for the supervised billing pieces of your billing in CCBHC, the agency will be the billing ID, and then the person who delivered the service or the supervisee is going in the attending or rendering position. I know there's a little bit of confusion or discrepancy maybe on what that word means in the EHR, but from the state side, the attending position and rendering are interchangeable words, and that is the supervisee.
Okay, thank you.
Mm-hmm.
Can I just clarify, for supervised billing, the agency will be in the billing ID, and the person delivering the services, who's the supervisee,
Mhm.
will go in the attending rendering.
Yes.
Thank you.
So we don't have to have the supervisor on the bill at all.
Mhm.
It just has to be in the documentation.
Correct, yes. Keep that documented, but it does not need to be on the claim.
I think VCP had a question. You keep going.
Did anybody else have a question?
Anyone else? No, I think we're good.
I think we've kind of touched on some of the lessons learned and you've brought them up, but I think a final point that maybe hasn't come up is just of anything that you can start to do for enrollment for your providers to get that started now and underway as soon as possible will be very helpful to you once the go live date starts, for those of you in the next cohort. We know that you cannot get your providers enrolled with Vermont Medicaid until the CCBHC itself is enrolled with Vermont Medicaid, but you can start the process of the NPI and taxonomy code. So I would encourage that as much as you can get that started now.
And can they start getting their provider ID, working on that with Gainwell for the CCBHC?
That is, yes, I think the CCBHC can start working towards enrollment.
Yes.
Mm-hmm.
So if you have all that in place well before, get your provider number, that will really help make things smoother. We don't want any delays in billings, and we don't want any issues with not being able to bill because of missed dates or anything like that. Like we don't have the ability to, I guess, pay for Medicaid service that's not, that doesn't have every single one of the components that's required. So I just want to make sure that folks understand that making sure that your enrollment is happening beforehand is really, really critical, because I don't want you to start providing services that you can't get paid for.
Patty's
Hey,
question.
clarification in the chat, I think, is helpful. Just to note that the CCBHC certification is required to get the CCBHC to final Medicaid enrollment. So that's just thanks for pointing that out, Patty.
Yes,
Go
thank
ahead,
you.
Sarah, or VCP.
No, that's exactly what I was gonna say. You need to be certified before you can start moving forward in that process, so.
Thank you. Good reminder.
I might want to add to check your OIG exclusions for any enrollment exceptions as well. If anybody doesn't know what that is, it's the list put out by the OIG.
And OIG stands for Office of,
Inspector General, I believe it's CMS uses that to decide whether or not to pay you.
thank you, pretty critical. So we do, we do, this meeting was scheduled to go until 11:30. We can obviously end early if we want to do that. I just want to make sure that there are not other topics folks want to touch on, that there are, that all the questions are have been asked and answered, and also to just make sure that to send in any questions to our mailbox, because if you have a question, and so chances are somebody else has the same question. And it may be something that we have to reach out to CMS on. So they have been taking a little bit of time to get back to us. It's not instantaneous. So we want to make sure that we get ahead of anything that you are needing.
Can we get a copy of the slides?
Yes.
Can those be sent out? That'd be great. Thank you. The questions in the room?
Shannon, Bill Clayson's from Counseling Service Madison County. In the presentation, you mentioned, or somebody mentioned support services. What's the source of truth for future consideration? Those are going up on the MSR. Is the MSR the source of truth to count those?
No.
Or
Yeah.
they're not getting submitted, so you don't know those? Or how do you know about those support services?
Good question. The MMIS is our source of truth, so to speak. So that is the most important place for us to receive and interpret the Medicaid billable data. There, I guess, in some ways, if you didn't report the support service, there wouldn't be an issue necessarily because you're not getting paid for it. So I can see there's this potential issue that could come up that maybe we forget to be billing the support services unless they were already, tied into your T1040 where you're billing some qualifying services. And so it's, I think, important to mention that because if they are not recognized in MMIS, we cannot then interpret the data to understand if your PPS rate is truly covering the service load. So it is really important to make sure those are billed, even if there's no qualifying service happening to the MMIS specifically.
So when those are submitted, that's not going, they will be denied and they won't get confused with the true billing that's being submitted. Is that correct?
They will not be denied. They'd be paid claims that are zero paid, if that makes sense.
Yeah. Okay. Thank you.
Sure.
Can I ask a clarifying question just for the notes? Are those support services also attached under the T1040 with the qualifying? Okay.
Yes, thank you.
Right. So if you provided services in one day to an individual where some of the services were qualifying and some were support, they would all go on the T1040 bill. But the next day you may serve somebody who is not getting a qualifying service. So the T1040 would not be on the bill. You would just send in a bill with all of the support services that were provided.
Yes.
Okay.
Good clarification.
And it would pay zero.
So if there are no qualifying services, the T1040 wouldn't
Be on the bill.
be on the bill, but the support services alone would be.
Correct. And actually, back to the question of whether it would deny or not, I think that is an instance where the support would deny if it was just a support service and there was a T1040 submitted with it. So if you are trying to bill for a support service only, do not include the T1040 in that case.
So let me repeat back what I think I heard on the T1040 and nursing service happened the same day. Both the T1040 or whatever the code is and the nursing service would have to be associated with the qualifying service, and the support service would have to go in with that claim.
Correct.
Yes.
Thank you.
Yeah, thank you.
Laura?
And then, hello, everybody. If you're a preferred provider with DSU, you also have to do the status with the MSR. So it's like a bunch of different systems too, because you have to use the status system with MSR with VIMS. So we're hoping one day, right, that it'll all be one system for the administrative burden piece.
Yes. Yes, yes. So the MSR is going to capture for us also services that were provided to non-Medicaid individuals, right? So we can only use the MMIS for payment and for accurate Medicaid data, but the MSR would also capture those services that are provided to individuals who are not Medicaid enrolled. So, yeah.
I just pointed that out for everybody if you're a preferred provider as well.
Yeah, thank you. Yes. Derek?
Hi. I just get your impression on like the future and the long term. I know back during an October TA call, I think with only the 4, we had talked about jobs, reach up, elder care going into CCBHC. I think there were comments that reach up and elder care are firmly out because of complexities. Jobs is also a complex thing, but maybe something to look forward to in the future, because I know there might be some discussion and thinking about like, well, where does Success Beyond 6 maybe fit in, DS mental health services and all that. And I didn't know if you had kind of like a gauge and a ranking of like what's low hanging fruit for the future, thinking long term, and what's just like, yeah, that's probably never going to happen.
Yeah, I think that we just are continuing. I don't know if Laura wants to chime in on this or Cheryl, but.
Well, this is Laura, and I don't know that we have a priority list to know, okay, this is an easy one for us to consider versus this one. So that's not a helpful answer.
Thought I'd ask.
Yeah, I mean, it's all been discussed, so those conversations will definitely continue. It's just, we don't have a priority listing right now.
Did we address Rob's?
Shannon, just along those lines, like you say, you don't have a priority list, but is your philosophically, what's your philosophical stance on adding on adding everything in? Agnostic of prioritization of what would go in. What's your philosophical stance?
I don't feel qualified to answer that question, especially since I'm retiring in December. I don't want to take that stand. I know that we're talking about Success Beyond 6, but I think that there's just so many complicating factors. It's just going to take some time. Laura, Cheryl, anything? Any thoughts?
I think what you said, Shannon, is great. Not about you retiring, but about the other pieces. I think, whenever we think about integrating other things, there are so many considerations, and we also have been so focused on moving towards implementation with the next 5 sites that I promise all of you, when we start talking about this more, we'll do it together and think it through. We haven't gotten there.
From our side, like we're finally at the place we have been thinking about it. It's like we took this square peg, which is our current services, and we jammed it into the round hole. And now we're trying to figure out like how can we adjust our services to kind of fit that round hole a little bit better. And just saying on your side, you've been doing the same thing, trying to get us all to this point. We've jammed the square pegs into the round holes. What's your philosophical approach on the other side? Because that's our philosophical approach on this side, or mine at least, is trying to figure out how do we now really adapt our agency to fit the payment model. And on the other side, are you also looking to adapt the payment model and the structure and the included services to fit the current kind of care continuum as well? I guess that's what I'm saying by like philosophical approach. Is your philosophical approach to try to include as much as possible in the regulations, or and I understand if you're not comfortable to answer, but I'm comfortable enough to ask the question. So
I appreciate the question. I think I think we're in knowing how much is changing and how much keeps changing at the federal level. I will say from the seat of, got some echo, the seat of having seen integration efforts, I think it is not something we want to decide quickly or without all the information. And certainly when Laura and I have talked with other states, we are talking to them about what they're including or what they're leaving out in decisions that are being made. I mean, I think with DS payment reform, I know you all are trying to get your feet under you with that. We're trying to see how that works as well. And then with all of the when you think about Success Beyond 6, all the pieces, the legislature and how that's going to impact funds or what that could do. I think it's just a really hard piece to have a really clear answer until some other things hit firmer ground. I'm not trying to avoid it. That's just honestly like where we're at. We've talked about it. We know there are things on the list. And we want to make sure this is successful with this next piece before we start trying to do even more.
Any other questions? VCP, do you have any more questions?
I think we're good. Although I said that before.
Okay. Well, we will send out the slide deck and the notes. And again, please, if you do have questions, please feel free to send them in. And hope you enjoy the rest of your day.
Thank you.
Hi, thank you.
Thank you.